Hi, everyone, and welcome back to another episode of the IGCS Education Podcast on Malignant Bowel Obstruction in Gynecological Cancer. I am Anisa Mburu, the Vice Chair of IGCS Palliative Care Education Workgroup. I am once again joined today with my co-moderator, Dr. Peter Grant. Nice to be back again. Dr. Grant, I'm excited about today's episode. How about you?
Yes, I am. I'm sure we're going to learn a lot. It'll be a good opportunity to talk.
Absolutely. Great, let's get started. Please welcome our guest speaker, Dr. Glauco Baiocchi. Dr. Baiocchi is a Brazilian surgeon who practices at AC Camargo Cancer Center. Thank you for joining us today, Dr. Baiocchi.
Hi, everybody. I'm very glad to be here and talk with you and discuss this very, very important topic, is the surgical management of malignant bowel obstruction. It's a great pleasure for me. Thank you so much for the invitation.
You're very welcome, and thank you for accepting our invitation. So today, Dr. Baiocchi will share his knowledge and expertise on surgical intervention with malignant bowel obstruction. We will discuss various procedures for large bowel obstruction, gastric outlet, and small bowel obstruction, and answer questions on when surgery is appropriate and what intervention best fits what situation. We'll also discuss some risks and benefits and conclude with post-surgical care details. Without further ado, let's get started. Now, my first question to you, Dr. Baiocchi. Malignant bowel obstruction, what exactly does the medical literature tell us?
Well, so it's first we need to contextualize our scenario, mainly on platinum-resistant disease for ovarian carcinoma. We need to remember that for the Aurelia study, the median overall survival for chemotherapy plus bevacizumab is only the median survival of 16 months. And even for the recent study, the Mirasol study with the ADC, the median overall survival with the ADCs is only 16 months too. So we need to face that mainly for ovarian carcinoma. The scenario of platinum-resistant disease is very, very bad for those patients. And when we talk about malignant obstruction in GY cancer, mainly we will face of ovarian carcinoma after platinum resistance. And generally, this is a terminal event. It occurs in about 50% of cases of ovarian carcinoma. And if you look at the autopsies, more than 70% show intestinal involvement of those patients. It's a very important topic. However, it's very difficult to address because we don't have good literature on it. We don't have prospective studies on it. We just have some published papers based on institutional experience. And going further on this, we have some studies. We have a memorial psychiatry study, and they showed on 74 palliative interventions for those patients with malignant obstruction. 35% was due to ovarian cancer, 54% of small intestine, and 46% for colon. They had 54% of the cases had palliative surgery, and another 46% had endoscopic treatment. But it is interesting because their experience, about 88% had the symptom improvement in 30 days, with a median overall survival, a good median overall survival of 190 months. It's very good for the surgical women. However, another study from Royal Marsden in UK, they included 90 patients with palliative surgery for bowel obstruction. The median interval from chemotherapy to obstruction, only 4 months. They had a mortality of 18%, morbidity of nearly 30%, and about 2/3 of patients had surgical success. They considered oral intake within 60 days, and the median survival was only 3 months. So it's a very, very, very poor scenario for those patients. In literature, we can find even going further with salvage surgery, large bowel resections. We have a study from Cristina Fotopoulou. It's an interesting study. They underwent large surgery resections for women. They included 37 women in their study. and the median small intestine length was only 70 centimeters. The mortality was 10%, 3-day morbidity of 50%, and the median overall survival here, that's most important, of only 5.6 months, ranging from 1 to 49 months. So it's a very it's not a good scenario for those patients that develop bowel obstruction, mainly related to ovarian carcinoma, and this occur mainly after platinum-resistant disease. So, and we have, when we look at literature, we have an interesting study by Sweden. They did a review from the SEER database, the large SEER database, American database, that included almost 1,400 cases of bowel obstruction. Of those patients, 40% received surgery, and 1/3 subsequent chemotherapy. 11% underwent gastrostomy, with 8% subsequent chemotherapy. But the numbers are nearly the same. Almost 70% of the women after surgery had complications, and 46% after gastrostomy have complications. And the overall survival is almost aligned in all studies the same. So a very bad overall survival. In this review, Sweden found 5.3 months overall survival for surgery versus 1.2 months for gastrostomy. Women that received chemotherapy, only 17 months after chemotherapy, and without chemotherapy, just palliative care, 3 months of median overall survival. So we have a very common situation in GY oncology, and so we have to think every time we have a patient with malignant bowel obstruction, what we're going to do with them, because it's a terrible situation. In the most of the time is we are doing a palliative treatment, and we need to somehow do the best for the patients.
And it's clear that it's a very challenging situation to manage. So when it comes to patient selections, how do you select the patients who will undergo surgery and who will not benefit from surgery?
So, in my opinion, in my practice, my daily practice, if we see a patient with ovarian carcinoma, the first question is if this patient is platinum resistant or platinum sensitive. So we need, and if this patient is platinum resistant, how many lines of cycle this patient have received. So we need to address and to assess the bowel obstruction with imaging. It's very important to have an imaging, mainly in the CAT scan for this patient. It's possible we do oral intake of contrast to see how it works, and we need to try to look the sites of obstruction, if it's small bowel obstruction or if it's large bowel obstruction, and if possible, number of sites of obstruction. So nowadays I do less and less surgeries for those patients, mainly for those platinum-resistant patients after 2 lines, 1, 2, 3 lines of chemotherapy, because mainly the palliative care will work. And for those patients, if they are receiving chemotherapy, palliative chemotherapy, and develop bowel obstruction, certainly the surgery will not do anything more for those patients. There is in literature we have I know 2 studies. I found 2 studies that try to address as a score which patient should go to surgery and what we are going to get with the surgery. One published paper is on Manchester score. It's from the group from Manchester. The main author is Emma Dean in 2017. They evaluated 129 women, and it was interesting because they used it's a Manchester Bowel Obstruction score. The score used just a cog, the performance status, and the obstruction level discriminated by the site of the site and the number of obstruction. If it's small bowel or of a large bowel, sorry. And it's interesting because depending on the score, if good performance status, 1 point of obstruction, the overall survival is about the median is about 180 days. And if you have all obstruction in more than the 2 points, a bad performance status, the overall survival is only 42 days. So I think we can use a very simple score like this, the Manchester score, to try to select patients, objectively select patients to do any intervention. There is another study from Duke University. The first author is Moyet in 2023. And they used, it's called ENHI score. It was a score developed for gastrointestinal cancer population. And in this score, it tries to predict the 3-day mortality for those women. It's very interesting. It's a score. It's difficult. You need to look at the score. And in this study from Duke University, they included 180 patients, and the majority were managed non-operatively. Just 10% underwent surgery. And it was interesting that no significant difference in survival between surgery or a medical treatment for those patients. And the ENHI score worked very well. If the women scored 0 to 1, no mortality in 30 days. And if it scored 4 to 5, 40% of mortality in 30 days. So it's a very interesting and predictive score for survival, for 30 days survival for those women. And it's a score that we can use. They include albuminia. They include many clinical data in this score.
Wonderful. And you've mentioned the site of obstruction. Could you go through how you would manage different sites of obstruction from gastric outlet to small and large bowel?
So in cases we have very diffuse carcinomatosis with bowel obstruction, I think that the palliative surgery won't work, and some gastric outlet like gastrostomy will work if we have those endoscopic treatment in the institution. If we have just one, it's important to remember that large bowel sections may not work for this patient too. And sometimes we need to face in a surgery that we need to leave at least 1.5 meters of small bowel. It's the limit if this patient has the large bowel. So it's not a good palliative surgery to resect large bowel length and leave these patients with small bowel syndrome, so with short bowel syndrome. Sometimes we can divide the treatment in just internal resection, sometimes a bypass. In my opinion, if you have some like a mass in the pelvis that is obstructing this patient can benefit from just a bypass, an ileocolonic bypass. So it works well. Sometimes this patient will benefit from a colostomy if the bowel obstruction is in the rectum. And in my opinion, we prefer to do a colostomy in the left colostomy. It works better than like a transversostomy. And sometimes, I prefer the bypasses and try not doing a colostomy or an ileostomy for those patients. Remember that the treatment is being palliative, and you mainly have it's easier to treat surgically those patients if we have just one point of obstruction, 1 or 2 points of obstruction. But it's very difficult to do surgery and decide interpretively what we are doing if you have a lot of sites of obstruction, and mainly on small bowel obstruction. Yeah.
Dr. Grant, you had a question?
Yeah, I did. In these platinum-resistant patients where the whole aim of treatment is symptom management, they've failed previous therapy, presenting with this distal small bowel obstruction, would you ever consider an enteroenterostomy, a bypass, without adequate evaluation of the large bowel preoperatively, or should you just say the default would always be a proximal stoma in the small bowel?
No, if I think if we are looking for just a bypass, we need to guarantee that there is no obstruction in the large bowel, because it won't work. The fistula rate will be very high because of the obstruction, distal obstruction, and I do think if we are looking to do just a bypass, we need to guarantee that there's no obstruction after this bypass. And if you have some obstruction, sometimes you need to resect this. Sometimes resect the site where it's obstructed. And if you have another obstruction, distal obstruction, and then an ileostomy or something like that, it's better to do. So I think those patients have just one chance of surgery. So we need to remember that it's a palliative treatment, and this patient has just one chance for this palliative surgery. And we need to mitigate the chance of the risk of any complication for those patients. So in doubt, do the ostomy, any ostomy for those patients, if you're in doubt.
Thank you. Thanks, Nisi.
Easy?
Yes, thanks for that. And I know you've said about ostomies, but what about temporary or percutaneous stomas? When patients are very sick, what those things you consider, or at what point will you consider them?
Temporary, stomas?
Yes, so percutaneous
yeah.
stomas.
Yeah, sometimes we have, that's very interesting to answer. So sometimes we have patients with bowel obstruction and for breast cancer with platinum sensitive women. Sometimes I think the platinum sensitive women need to wait for the sensitivity of the chemotherapy. It works. Sometimes this obstruction goes away. For those platinum sensitive women, I wait the chemotherapy with medical treatment, associated medical treatment, and mainly this bowel obstruction goes away. So I wait for those men. And sometimes it's not possible, and the temporary ileostomy, when we do a rectal resection, and if this rectal resection is very near the anus, we need to do ileostomy, protective ileostomy, mainly if this patient had received radiotherapy before. It will be for cervical cancer or endometrial cancer. And after if this patient responds to chemotherapy and there is no more obstruction, I think we can fix and close this ileostomy for this patient, come back to the normal evacuation system. Okay. That's yeah, Nisi?
Could I ask one more question?
Yeah.
In resource limited settings, in patients where you've considered surgery, any special tips about post-surgical management where you may not have great access to blood, and all these other things? Any tips that we can use for these patients in terms of post-surgical management?
Yeah. This patients usually need parenteral nutrition, so that's a huge problem in low middle income countries. But it's very important to have parenteral nutrition. Those patients usually the surgery we don't expect any bleeding at all, so it usually goes very well in this. And it's from a surgical perspective, I think the main difference in countries would be the staplers. It's easier to do surgery when we have some staplers, some bowel resections and something like that. But it's possible to do surgery without staplers and without fancy devices.
Yes.
For ostomies, we don't need any stapler, any fancy devices. And it's common. For the gastrostomy, the endoscopic gastrostomy, we don't have endoscopic gastrostomy in many places, even in Brazil. So, but it's possible to do a gastrostomy or some surgical derivation open surgery. So it's possible to do it open, and it may work. It may work well. Yeah, even in low resource settings.
Okay. Thank you. Thank you very much. I'll pass it back to you now, Nisi.
Thanks, Dr. Grant. I think one thing that I wanted to know, especially in the post-surgical care, how soon do you usually start them feeding, and how often do we expect them to be at least symptom-free?
Yeah, that's one of the main objectives, to feed these patients. So it's one of the main goals of the surgery or any treatment, even endoscopic treatment, gastrostomy, anything, is to try to feed these patients. So I think the main goal is that this patient is eating in 30 days. So in 30 to 60 days, discharged from the hospital. In 30 to 60 days, mainly the main objective is 30 days to start to feed and to discharge the hospital in 30 days. It would be the best and the main objective for those patients. But it's very difficult. Sometimes one interesting topic is mainly we can feed those patients, but we need to adapt the food. Sometimes it's not possible to eat everything. It's sometimes not possible to eat solid food, but if this patient can have some supplements, some nutritional supplements, oral take, and feed oral feed, it would be great in 30 days. Okay.
This has been quite informative. I think what's coming out clearly is we need to be able to balance whether we are using interventions to prolong life or for symptom relief. And that's quite a bit of a delicate balance. I think I've learned a lot. Thank you so much, Dr. Baiocchi, for joining us today and talking about this. I mean, I hope all the listeners will feel the same. I don't know. What about you, Dr. Grant?
Oh, I agree. No, I think it was great overview of this difficult topic at end of life management.
Yeah, thank you so much. I think we need to personalize and keep in mind that the treatment is palliative, and we need to look for the best for the patient. So as a surgeon, I really struggle to indicate surgery for those patients nowadays. So because the prognosis is not good, even with surgery, even with chemotherapy. even with anything we are doing for those patients. And we need to keep in mind that it's a palliative treatment. And as a palliative treatment, we need to do the best supportive care for those patients with less pain, with less suffering, and sometimes surgery works. And works better not in the end of the treatment of this patient. So when this patient somehow may need just supportive care.
Thank you.
So multidisciplinary care is one of the cornerstones in managing these patients. Well, thank you so much, Dr. Baiocchi, and thank you, Dr. Grant, and thank you, IGCS, for having us. So to our listeners, we want you to tune in next time for our final podcast in this series as we discuss future directions and cutting-edge research. Our expert guest speaker will share their take on emerging treatments and where we can still improve. Thank you all for listening.